Hello, I am Dr. Nasmani, and this is the sixth session of the cardiology for the practice of postgraduate medical entrance test session. Please visit my channel youtube.com/acpgmet for seeing the previous editions of this video. Already 5 have been uploaded, and also practice sessions which will be coming in the future. You can use the pause button to freeze the video till you finish the reading and press play button to resume if you feel the video streaming is faster. The audio may be a little faster, but you can always replay the video so that you can listen to the audio again and again. The revision becomes easier because all the videos are less than 15 minutes and doesn't take much of your video broadband. More similar sessions you can get from my channel youtube.com/acpgmet. The question number 1 of today is myocarditis is a recognized association of salmonella infection, mycoplasma infection, Lyme disease, measles, and Hurler syndrome. State which are true and which are false. Even though in the Kerala and All India entrance exam there may not be true or false statement, for the sake of discussion purpose I am putting the questions in such a way. The same question can be asked in a different way so that only one option will be right. So the idea of this true-false system is to drive a concept into your mind so that 5 questions may be attempted by the same from the same question by the student, because the concept is also discussed along with most of the questions which I will be uploading. So let us see which are the true. Except the Hurler syndrome, all other facts are true. So what is the important clue here? All of them are infections, and Hurler syndrome is a storage disorder. So the principle is that any infective agent can affect the heart just like any other organ like lung, liver, kidney, brain, where you can get inflammation due to the antigen invasion, whereas Hurler syndrome is a storage disorder. The storage disorders we will be discussing in another video session as a separate case, but I will briefly go through some of these features of Hurler syndrome. Hurler syndrome is associated with cardiomyopathy, which is most often not discussed during the presentation of Hurler's. That's why I am discussing that part in the CVS section. Hurler syndrome is the severe form of mucopolysaccharidosis 1 and is characterized by a broad spectrum of clinical problems, including skeletal abnormality, hepatosplenomegaly, and severe mental retardation. Intellectual disability is there. They appear normal at birth, and during the first year they develop the characteristic coarse facial features, wide nasal bridge, and flattened midface. Other features are hepatosplenomegaly, umbilical or inguinal hernia, and typical skeletal abnormality called dysostosis multiplex. In the X-ray which is I am showing, the dysostosis multiplex with the hypoplasia of the anterosuperior areas of the lower thoracic and upper lumbar vertebral bodies, resulting in prominent beaking of the lumbar vertebral body by the arrow is shown. And the picture on the right side, 2 children of the same, the face and the whole body is shown. And this video shows the dysostosis multiplex manifest as proximal pointing of the metacarpals in the left frame, and on the right side you can see the dysostosis multiplex seen on the lateral skull radio with the expansion of the sella turcica. The question number 2 is the following are the features of aortic coarctation in infancy, which are true or false. Rib notching, inverted T wave in V6, ejection systolic murmur between the shoulder blades, radiofemoral delay, and plateau pulses. State which are true and which are false. There are 2 false statements, rib notching and plateau pulses. Please read the question. It is aortic coarctation in infancy. The age is mentioned. That means the features of coarctation alter depending on the age. Inverted T wave in V6 is true. Ejection systolic murmur between shoulder blade is true. And the radiofemoral delay can be better expressed as decreased ephemeral pulse. Of course, hypertension also may be got. We will discuss that. Rib notching is a late sign in adolescence and is rarely seen in infancy. An inverted T wave in V6 suggests a left ventricular strain. Plateau pulses are a feature of aortic stenosis, not an aortic coarctation. And in the left side picture, you can see the 3D reconstruction of the coarctation. This picture shows the red arrow pointing to the rib notching caused by the dilated intercostal arteries. The yellow arrow points to the aortic knob, the blue arrow to the actual coarctation, and the green arrow to the post-stenotic dilatation of the descending aorta. The chest X-ray is helpful in diagnosis, but not in an infant. This is X-ray of an adult. And the 3D picture on your left side shows the coarctation, which is visible by the new modern techniques of reconstruction by rendering in CT and MRI. The rib notching is a single best sign to diagnose coarctation of aorta. Older the person, more likely to have rib notching. Majority have it over 20 years of age. Rib notching occurs in the high pressure circuit. Most often involves 4th to 8th rib. Sometimes may involve 3rd and 9th. Does not involve 1st and 2nd ribs. Intercostals come off costocervical trunk and do not supply collateral flow to descending aorta. 4 to 8 do anastomose with the internal mammary to form collaterals for descending aorta. The rib notching unilateral, you can see isolated right sided notching occurs when LSCA is involved, that is left subclavian is involved in actual coarctation. Isolated left sided notching can occur if there is an aberrant RSCA which arises from below the coarctation. Figure 3 sign caused by, in order, either a dilated LSCA or aortic knob, truck of the coarctation itself, and post-stenotic dilatation occurs in 1/3 to half of the patients with coarctation, matched by the reverse 3 or E on barium filled esophagus. Convexity of the left side of mediastinum just above aortic knob 2 degree to secondary to dilated LSCA. Convexity of the ascending aorta in 1/3 of the patients. The tortuous vessels are shown in this 3D reconstruction picture. Diagnosis of the coarctation of aorta. ECG varies with age and severity of the coarctation. ECG may be normal, but infants with the severe coarctation display pure right ventricular hypertrophy. In older children and adult, ECG may be normal or show left ventricular hypertrophy with increasing voltage and STT changes in the left precordial leads. ECG will occasionally show right ventricular conduction delay. The chest radiograph varies with age and severity of the coarctation. In infants with heart failure, the chest X-ray shows generalized cardiomyopathy with increased pulmonary vascular markings due to pulmonary venous congestion. Echocardiography, as recommended in the 2008 ACC/AHA guideline for adult congenital heart disease, transthoracic is a echocardiography including suprasternal notch views is useful for initial imaging and hemodynamic evaluation in suspected coarctation. The differential diagnosis of T wave inversion, Q wave and non-Q wave MI, Example, evolving anteroseptal MI, myocardial ischemia, subacute old pericarditis, myocarditis, then myocardial contusion from trauma, CNS disease causing long QT interval, especially subarachnoid hemorrhage. Then continuation of the different lines of TV inversion, idiopathic apical hypertrophy, it's a rare form of hypertrophic cardiomyopathy, mitral valve prolapse, digoxin effect, and RVH and LVH with the strain. T wave inversion is seen in this lead AVL V4 to V6 in LVH. Diagnosis of coarctation by cardiac examination. The cardiac examination may be normal except for continuous murmur from collateral vessels by the internal thoracic, intercostal, subclavian, and subscapular arteries. Systolic murmur from coexisting cardiac defects like PDA, VSD, or aortic stenosis may be seen. The first and second heart sounds are usually normal if there are no associated cardiac anomaly. When pulmonary hypertension is present, the pulmonary component of the second heart sound is accentuated. There may be an ejection systolic click and ejection systolic murmur from the bicuspid aortic valve that is heard burst at the apex. A short mid-systolic murmur can be extend beyond the second heart sound at the left paravertebral interscapular area due to flow across the narrow coarctation area. Continuous murmurs may be caused by flow through the large collateral vessels. In infants with heart failure, a prominent right ventricular impulse is typical. In older children and adults, the left ventricular impulse is palpable and sustained, and the pulsations may be palpable in the intercostal spaces from large collateral arteries. Diagnosis of coarctation continued. Origin of the left subclavian artery is proximal to the coarctation, resulting in hypertension of both arms. And classic findings are hypertension in the upper extremities, diminished or delayed femoral pulses like this brachial femoral delay, and low or unobtainable arterial blood pressure in the lower extremities. I am showing the picture of normal dicrotic bounding tortuous plateau pulse, alternance pulse by Gemini and paradoxes. You can freeze the frame and see the recordings. You can freeze this frame and read because the timing is less, so I cannot dictate this part. So hope that session was useful to you. Next session will be uploaded tomorrow. Bye.